Welcome to our first video on obstructive lung disease. Let's begin. In this lecture, we will discuss chronic obstructive pulmonary disease and alpha-1 antitrypsin deficiency. Let's start with chronic obstructive pulmonary disease. For chronic obstructive pulmonary disease, we will talk about the general features, pathophysiology, clinical presentation, diagnosis, management, and complications. Chronic obstructive pulmonary disease, also known as COPD, is a combination of chronic bronchitis and centroacinar emphysema. It is common in long-term smokers. Let's talk about the pathophysiology of chronic bronchitis first, and then we will discuss centroacinar emphysema. Patients with chronic bronchitis are sometimes called the blue bloaters because they cannot maintain normal oxygen saturation, and they become cyanotic. Additionally, they are usually overweight or obese. In these patients, the exposure to cigarette smoke induces hypertrophy and hyperplasia of mucus glands in the bronchial wall. The relative size of mucus gland layer is determined by the Reed index, which is the ratio of thickness of the mucus gland layer to the thickness of the bronchial wall between the epithelium and cartilage. In chronic bronchitis, the Reed index becomes more than 50%. Due to abundant mucus production, patients with chronic bronchitis have a productive cough. This is a patient with chronic bronchitis predominant COPD. Please notice the blue discoloration of his skin, indicating hypoxemia. Let's move on to the pathophysiology of centroacinar emphysema. First, it's worth mentioning that patients with emphysema-predominant COPD are sometimes called pink puffers, because in the initial stage of disease, they maintain their oxygen saturation. Therefore, their skin is a normal pink color. Additionally, when they exhale, they purse their lips and puff their cheeks in order to prevent airway collapse. In these patients, cigarette smoke decreases activity of alpha-1 antitrypsin in the lungs. Normally, alpha-1 antitrypsin inhibits neutrophil elastase in the alveoli. Therefore, deficiency of this enzyme disinhibits the neutrophil elastase, which then degrades elastic tissue around the respiratory bronchioles. This results in dilation of respiratory bronchioles, which are the central segment of the acinus. This is where the name centroacinar is derived from. Additionally, centroacinar emphysema mostly affects the upper lobes. This is due to the fact that gravity has a minimal effect on cigarette smoke. Therefore, smoke goes predominantly in the upper lobes and causes damage there. Again, let's keep in mind that chronic obstructive pulmonary disease is a combination of the two pathophysiologies that have been discussed, chronic bronchitis and centroacinar emphysema. Here we have a patient with emphysema-predominant COPD. Please take note of his pursed lips during exhalation in an attempt to prevent airway collapse. This is an illustration comparing centroacinar emphysema to panacinar emphysema. Please note that only the respiratory bronchiole is dilated in centroacinar emphysema, while the respiratory bronchiole, alveolar ducts, and alveoli are all dilated in panacinar emphysema. Let's keep in mind that the emphysema associated with chronic obstructive pulmonary disease is centroacinar. The clinical presentation of chronic obstructive pulmonary disease includes a productive cough due to abundant mucus production. Additionally, the patient may also experience dyspnea and cyanosis from insufficient oxygenation. Wheezing occurs secondary to narrowing of the bronchial lumen due to mucus. Inspiratory crackles occur due to distorted alveoli opening up during inhalation. Additionally, patients with COPD may have appropriate absolute polycythemia. Polycythemia in these patients is appropriate because it develops in response to hypoxia. Chronic hypoxia causes excessive erythropoietin production from the kidney, which then stimulates the bone marrow to produce more red blood cells. Therefore, the patient with long-standing COPD usually has a high hemoglobin and hematocrit. Let's talk about the diagnosis of COPD. Since COPD is an obstructive lung disease, barometry will reveal an obstructive pattern with a FEV1/FVC ratio of less than 70%, FEV1 less than 80%, and FVC of less than 80%. Importantly, these parameters do not improve significantly with bronchodilator administration. This is why COPD is considered irreversible or minimally responsive to bronchodilators in contrast to asthma, which is mostly reversible. Chest X-ray of the patient with COPD will show lung hyperinflation and increased lung-filled lucency due to excessive air retention. Additionally, the diaphragm will be flattened due to the expanded lungs. Arterial blood gases will show chronic respiratory acidosis due to persistent CO2 retention. It is worth noting that chronic bronchitis is largely a clinical diagnosis. The patient should have a productive cough more than 3 months per year for at least 2 consecutive years. This is a chest X-ray of a patient with COPD. Please notice the pulmonary hyperinflation and increased lung-filled lucency and the flattened diaphragm. Management of chronic obstructive pulmonary disease depends on the severity of the patient's condition. The more severe the patient's COPD is, the more medications he or she usually takes. Baseline therapy involves short-acting beta-2 agonists such as albuterol or short-acting muscarinic antagonists such as ipratropium as needed. If the patient continues to experience symptoms, long-acting beta-2 agonists such as salmeterol or formoterol and long-acting muscarinic antagonists like tiotropium can also be added to the therapy. If the patient is still symptomatic, one can add inhaled corticosteroids and increase their dose based on severity of symptoms. If the patient is still symptomatic, then one can add oral steroids or prescribed roflumilast or theophylline. Roflumilast is a phosphodiesterase 4 inhibitor which decreases bronchial inflammation. Theophylline, on the other hand, is a nonspecific phosphodiesterase inhibitor that leads to bronchodilation. These medications are only used in refractory COPD due to their side effect profiles and potential for toxicity. All COPD patients should be advised to stop smoking to prevent further progression of their condition. It's very high yield to know the criteria for home oxygen therapy, also known as long-term oxygen therapy. COPD patients are eligible for long-term oxygen therapy if their PO2 is less than 55 or SaO2 is less than 88. However, if they have cor pulmonale, which is right-sided heart failure secondary to chronic lung disease, or polycythemia with a hematocrit of greater than 55%, then they should start home oxygen therapy when their PaO2 is less than 59 or their SaO2 is less than 89%. It's worth mentioning that the only interventions that increase survival in patients with COPD are smoking cessation and oxygen therapy. If COPD is refractory to all the therapies that we discussed so far, then one can consider lung transplantation. Now let's talk about the management of an acute COPD exacerbation. The first step in management is to give the patient oxygen with a goal oxygen saturation between 88 and 92%. As we already mentioned, COPD patients are chronic CO2 retainers. Therefore, their peripheral and central chemoreceptors are desensitized to CO2 levels, and the respiratory drive is guided mainly by low oxygen levels. If one brings their oxygen saturation up to the normal range of 95 to 99%, the patient will lose their respiratory drive and may develop respiratory failure. Additionally, inhaled bronchodilators are given to relieve dyspnea, while systemic glucocorticoids are given to decrease airway inflammation. Antibiotics are also administered to the patient with COPD exacerbation if the patient has at least two cardinal symptoms. If influenza is suspected as a possible cause of acute COPD exacerbation, one can give oseltamivir to the patient. Oseltamivir is administered if the patient presents within 48 hours of symptom onset. Beyond 48 hours, the efficacy of neuraminidase inhibitors, including that of oseltamivir, is uncertain. Finally, if a patient develops respiratory failure, they will require non-invasive positive pressure ventilation. If non-invasive positive pressure ventilation is ineffective, or the patient has contraindications to NPPV, one can intubate the patient. Now let's discuss acute COPD exacerbation. An acute COPD exacerbation is most commonly triggered by viral upper respiratory infections. Cardinal symptoms of COPD exacerbation include increased dyspnea, more severe and more frequent cough, and change in sputum color or volume. Presence of at least one of these symptoms raises suspicion for an acute COPD exacerbation. A chest X-ray is performed to rule out other pathologies like pneumonia or pulmonary edema. Arterial blood gases, on the other hand, will show CO2 retention and an acute or chronic respiratory acidosis. COPD patients usually have chronic respiratory acidosis due to persistent CO2 retention. However, when they develop an acute exacerbation, their CO2 retention worsens, resulting in further decreased plasma pH. Let's pause the video to consider this question. A 67-year-old man is admitted to the emergency department due to severe shortness of breath and increased sputum production. He reports mild dyspnea at baseline, but his condition worsened 5 days ago. Past medical history includes a common cold 7 days ago. He has been smoking 2 packs of cigarettes per day for 50 years. Arterial blood gases reveal pH of 7.3, PaCO2 of 65, and HCO3 of 28. The physician decides to start antibiotic therapy, the presence of which findings makes the patient eligible for antibiotic therapy. The patient presents with exacerbated shortness of breath and increased sputum production. He has a past medical history of recent common cold that may have triggered his current symptoms. He is a long-term smoker. Arterial blood gases reveal a respiratory acidosis. All of these findings indicate an acute COPD exacerbation. Antibiotic therapy is initiated in patients with COPD exacerbations if he or she has at least 2 cardinal symptoms. This patient has exactly 2 cardinal symptoms: shortness of breath and increased sputum production. This is why he is eligible for antibiotic therapy. Let's discuss alpha-1 antitrypsin deficiency now. For a alpha-1 antitrypsin deficiency, we will talk about the general features, pathophysiology, clinical presentation, diagnosis, and management. Alpha-1 antitrypsin deficiency is caused by deficiency of alpha-1 antitrypsin, which is a protease inhibitor. It is a co-dominant genetic disease. In other words, both alleles of the gene are simultaneously expressed. Let's discuss the pathophysiology of alpha-1 antitrypsin deficiency. Misfolded alpha-1 antitrypsin levels lead to damage in the lungs and accumulate in the liver. Let's describe the pathophysiologic steps in detail on the next slide. Normally, alpha-1 antitrypsin inhibits neutrophil elastase in the lungs. However, decreased release of misfolded alpha-1 antitrypsin from the liver into the blood disinhibits neutrophil elastase. Without alpha-1 antitrypsin to inhibit it, neutrophil elastase destroys elastin fibers in the pulmonary interstitium. A decreased amount of elastic fibers results in decreased elasticity, dilation of the whole respiratory zone, and therefore a pan-acinar emphysema. Misfolded alpha-1 antitrypsin also accumulates in the rough endoplasmic reticulum of hepatocytes. Resultant hepatocyte dysfunction leads to cirrhosis. Due to the mechanism that we discussed on the previous slide, alpha-1 antitrypsin deficiency presents as cirrhosis and pan-acinar emphysema in a relatively young patient with no or minimal history of smoking. As we discussed in this lecture, development of emphysema is usually associated with a long history of smoking. Therefore, if you see a patient in their 30s or 40s developing emphysema with no or minimal smoking history, always have alpha-1 antitrypsin deficiency in your differential diagnosis. Let's briefly revisit this slide comparing centroacinar emphysema to pan-acinar emphysema. Please note that only the respiratory bronchiole is dilated in centroacinar emphysema, while the respiratory bronchiole, alveolar duct, and alveoli are all dilated in pan-acinar emphysema. Patients with alpha-1 antitrypsin deficiency will have a pan-acinar emphysema since there will be a loss of elastic fibers throughout the entire respiratory tract. As for the diagnosis, a chest X-ray in a patient with alpha-1 antitrypsin deficiency will show the typical findings of obstructive lung disease that we discussed for COPD. These include increased AP diameter, hyperlucent lungs, and a flattened diaphragm. A liver biopsy can also be performed. One can also directly measure the serum alpha-1 antitrypsin levels. Additionally, although not routinely used, one can perform a serum protein electrophoresis that will show a decreased peak of alpha-1 globulin. Management of alpha-1 antitrypsin deficiency includes smoking cessation if the patient is a smoker. The typical therapies for emphysema should be initiated as well. As for cirrhosis, transplantation is performed in severe cases. Finally, one can perform alpha-1 antitrypsin replacement therapy. A 35-year-old man comes to the physician due to shortness of breath that he first noticed 1 year ago. His dyspnea has worsened since then. The patient has been smoking 1 pack of cigarettes per day for the last 3 years. Family history is significant for death of his father from cirrhosis at the age of 49. The patient has also noticed weight gain and abdominal distension. The physical exam reveals a distended abdomen with a positive fluid wave test. Chest X-ray reveals diffuse hyperinflation and hyperlucency of the lung fields and a flattened diaphragm. Several tests, including liver biopsy, are ordered to confirm this patient's diagnosis. What lifestyle change should be recommended to this patient? This relatively young patient presents with gradual shortness of breath and abdominal distension with a positive fluid wave test. He has minor smoking history, and his family history is significant for his father dying from cirrhosis at a relatively young age. All these findings indicate the presence of a genetic condition. The obstructive lung disease evidenced by chest X-ray findings and ascites due to cirrhosis in a young patient suggests the diagnosis of alpha-1 antitrypsin deficiency. Patients with alpha-1 antitrypsin deficiency should be advised to avoid smoking in order not to accelerate progression of pan-acinar emphysema. A 75-year-old man comes to the physician for a regular checkup. He was diagnosed with hypertension and chronic obstructive pulmonary disease 15 years ago. He takes captopril for his blood pressure, and he uses albuterol, salmeterol, intermediate dose inhaled corticosteroids, and oxygen therapy for his COPD. He exercises 5 days a week, and he also eats healthy food. He lost 4 kilograms in the past month with his exercise and diet. He still smokes 3 cigarettes a day. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 130/75, a heart rate of 89, and a respiratory rate of 14. Physical exam reveals an increased antero-posterior chest diameter. Which of the following most likely increases survival in this patient? A. Oxygen therapy, B. Exercise, C. Weight loss, or D. Blood pressure control. This patient was diagnosed with chronic obstructive pulmonary disease. He takes albuterol, salmeterol, intermediate dose inhaled corticosteroids, and the oxygen therapy for his COPD. He also exercises 5 days a week and controls his blood pressure with captopril. Despite his multiple healthy habits, only 2 interventions increase survival in patients with COPD: smoking cessation and oxygen therapy. He still smokes cigarettes, but he is on oxygen therapy. Therefore, the correct answer is A. This is a slide summarizing the management of chronic obstructive pulmonary disease. Let's discuss why other options are incorrect. Option B, C, and D are incorrect because although exercise, weight loss, and blood pressure control improve the patient's overall quality of life, they do not increase survival in a patient with COPD. And that concludes our first lecture on obstructive lung diseases.